Hello, this is Dr. Evan Lipson from the Johns Hopkins Sidney Kimmel Comprehensive Cancer Center in Baltimore, Maryland. Welcome to this peer-view in-motion activity focused on immunotherapy dosing. In this educational program, we will use dynamic infographic visualization and animations to explore the pros, cons, and practicalities of clinical use of established and alternative dosing regimens of immunotherapies and combinations in oncology. Illustrated here are cellular interfaces where immune checkpoint blocking therapy is active. In the interface between a dendritic cell and a T cell, the T cell receptor engages with its cognate antigen presented by the dendritic cell. This step in T cell activation is often called signal 1. The B7 protein on the dendritic cell surface interacts with the CD28 receptor on the T cell, which provides a second signal promoting T cell survival, activation, and proliferation. CTLA-4 binds B7 with greater affinity than CD28 and transmits an inhibitory signal to T cells. Blocking CTLA-4 with Ipilimumab prevents the transmission of that inhibitory signal. Also illustrated here is the tumor microenvironment. Here, inactivated T cells expressing PD-1 engage with ligands PD-L1 and PD-L2. These interactions downregulate the activity of T cells. PD-1 and PD-L1 blocking antibodies prevent this downregulation, thereby allowing for activation and proliferation of T cells. Immune checkpoint blocking therapy, in particular antibodies blocking the pathway comprised of PD-1 and its ligands, is now a standard of care treatment for patients with a wide variety of malignancies. As of February 2021, PD-L1 and PD-1 antibodies have been FDA approved for patients with approximately 20 cancer types or tissue agnostic conditions. Immune checkpoint blocking antibodies are often administered as a component of anti-neoplastic therapy in combination with antibodies blocking other immune checkpoint molecules, oncogenic pathway inhibitors, cytotoxic chemotherapies, and angiogenesis inhibitors, among others. In order to maximize the efficacy of PD-1 and PD-L1 blocking antibodies, an increasing number of clinical trials are testing these agents as part of multimodality therapy. In many cases, the rationale behind these studies lies in bypassing resistance mechanisms that render PD-1 and PD-L1 monotherapies ineffective in generating anti-tumor immunity. As the development of immune checkpoint blocking therapy has evolved, a variety of dosing regimens, intervals, and methods have been investigated. For example, several therapies have been tested and FDA approved using both weight-based and flat dosing strategies. This has resulted in both increased flexibility and complexity for clinicians and patients. Although fixed or flat dosing of medications can streamline dose preparation, inventory stocking, and billing, the cost of a therapy can be higher on a per-patient basis. Weight-based dosing personalizes the dose of drug to the patient. However, appropriate vial sizes may not be available, and reimbursement policies surrounding leftover drug can be complex. Intervals between doses of PD-1 and PD-L1 antibodies have been widely tested over the past several years. In the first in-human trial of the drug that would later be named Dervalumab, patients received therapy once every 3 months. Despite the lengthy interval between doses, objective evidence of anti-tumor immunity was observed. Subsequently, most immune checkpoint inhibitors were tested using either every 2-week or every 3-week schedules. More recently, for some antibodies, extended interval dosing regimens, including every 4 and every 6-week administrations, have been approved by the FDA. The COVID-19 pandemic has further amplified the need for greater flexibility in immune checkpoint antibody administration, including extended interval dosing. Indeed, recommendations from some oncology professional societies suggest using extended dosing intervals to limit resource utilization and contact with the medical system in order to decrease COVID-19 transmission risk. Several early phase studies of anti-PD-1 therapies demonstrated an acceptable safety profile and generation of anti-tumor immunity at a variety of dose levels. After FDA approval of Nivolumab, dosed at 3 milligrams per kilogram of body weight every 2 weeks, a modeling and simulation approach was used to explore the impact of extending the dosing regimen. These analyses demonstrated that the benefit-risk profile associated with the 480 milligram every 4-week regimen would mirror the approved 3 milligram per kilogram every 2-week regimen. This concept was explored clinically in the Checkmate 384 trial, which compared the safety and efficacy of Nivolumab administered at a flat dose of 480 milligrams every 4 weeks versus 240 milligrams every 2 weeks in patients with non-small cell lung cancer who were being treated in the second line. Safety profiles and rates of progression-free survival were similar between the two groups. A similar pattern emerged with Pembrolizumab, also a PD-1 antibody. Data from simulated pharmacokinetic modeling and exposure response assessments demonstrated that Pembrolizumab dosed at 400 milligrams every 6 weeks would be expected to produce efficacy and safety signals similar to those seen with 200 milligram every 3-week dosing. In clinical trial Keynote 555, approximately 100 patients with advanced melanoma were treated with Pembrolizumab 400 milligrams every 6 weeks. Pharmacokinetic data were used to validate the model-based assessments, and safety and efficacy signals were compared to those seen in previous studies testing every 2 and every 3-week Pembrolizumab in patients with advanced melanoma. Outcomes from the study supported administration of Pembrolizumab 400 milligrams every 6 weeks. Dosing regimens for Atezolizumab, a PD-L1 antibody, were tested using in silico analyses of exposure response models for non-small cell lung cancer and urothelial carcinoma. In that study, no significant exposure safety or exposure efficacy relationships were observed, supporting the interchangeability of the dosing regimens listed here. In clinical practice, dosing flexibility often depends on indication. For some indications, Atezolizumab is administered in combination with another agent, and the two drugs are dosed at synchronized frequencies. For example, in patients with hepatocellular carcinoma, Atezolizumab and bevacizumab are administered on the same day every 3 weeks. Based on modeling of pharmacokinetic data and exposure relationships for safety, Dervalumab, another PD-L1 antibody, was FDA approved to be administered at 1,500 milligrams every 4 weeks for patients that weigh greater than or equal to 30 kilograms. Patients who weigh less than 30 kilograms receive 10 milligrams per kilogram every 2 weeks. Ipilimumab, a CTLA-4 blocking antibody, has been tested in multiple clinical trials at various dose levels. In contrast to much of the data supporting dosing flexibility of PD-1 and PD-L1 antibodies, modulating the dose of Ipilimumab appears to have a substantial impact on the toxicity profile. Checkmate 511 was a phase 3b/4 trial that evaluated 2 dosing regimens of Ipilimumab and Nivolumab for patients with advanced melanoma. Patients were stratified by program death ligand 1 or PD-L1 expression status and M stage, and randomly assigned to receive either Nivolumab 3 milligrams per kilogram plus Ipilimumab 1 milligram per kilogram, so-called Nivo3 plus Ipi1, or Nivolumab 1 milligram per kilogram plus Ipilimumab 3 milligrams per kilogram, termed Nivo1 Ipi3. Of note, this study excluded patients with active brain metastases. With approximately 180 patients in each arm, treatment-related grade 3 through 5 adverse events were seen in approximately 1/3 of patients who received low-dose Ipilimumab and approximately 1/2 of patients who received high-dose Ipilimumab. This difference was statistically significant with a p-value of 0.006. Although the study design only allowed for descriptive comparisons of efficacy among subjects who received Nivo3 plus Ipi1 and Nivo1 plus Ipi3, overall response rates were similar between the two groups, including across patient subgroups such as baseline serum LDH levels, BRAF mutation status, and PD-L1 expression in the tumor microenvironment. Curves comparing progression-free survival and overall survival are shown here. Nivolumab is FDA approved for patients with unresectable or metastatic melanoma, or for patients with melanoma who are being treated in the adjuvant setting. Additionally, nivolumab is approved for patients with non-small cell lung cancer, renal cell carcinoma, head and neck squamous cell carcinoma, classical Hodgkin's lymphoma, urothelial carcinoma, hepatocellular carcinoma, and esophageal cancer. In those indications, nivolumab may be dosed at 240 milligrams every 2 weeks or 480 milligrams every 4 weeks. For patients with MSI-high or mismatch repair deficient metastatic colorectal cancer, adult patients may receive nivolumab at 240 milligrams every 2 weeks or 480 milligrams every 4 weeks, where pediatric patients or those weighing less than 40 kilograms receive nivolumab at 3 milligrams per kilogram every 2 weeks. Ipilimumab, used for patients with unresectable or metastatic melanoma, is dosed at 3 milligrams per kilogram every 3 weeks for a maximum of 4 doses. Ipilimumab, used for adjuvant treatment of patients with melanoma, was tested at 10 milligrams per kilogram every 3 weeks for 4 doses, then 10 milligrams per kilogram every 12 weeks for up to 3 years. Importantly, high-dose ipilimumab at 10 milligrams per kilogram is associated with a high incidence of immune-related adverse events. In situations where ipilimumab may be used in the adjuvant setting, for example, in patients who progress during anti-PD-1 therapy with resectable disease, the recommendation from the National Comprehensive Cancer Network is to dose ipilimumab at 3 milligrams per kilogram. Ipilimumab and nivolumab used in combination is approved by the FDA for several indications. For patients with melanoma or hepatocellular carcinoma, nivolumab 1 milligram per kilogram followed by ipilimumab 3 milligrams per kilogram on the same day every 3 weeks for 4 doses are administered, followed by either nivolumab 240 milligrams every 2 weeks or 480 milligrams every 4 weeks. For patients with renal cell carcinoma or MSI-high or mismatch repair deficient colorectal cancer, adult and pediatric patients over or equal to 40 kilograms of body weight receive nivolumab 3 milligrams per kilogram followed by ipi 1 milligram per kilogram on the same day every 3 weeks for 4 doses, followed by nivolumab 240 milligrams every 2 weeks or 480 milligrams every 4 weeks. For patients with metastatic non-small cell lung cancer, nivolumab and ipilimumab are dosed with nivo 3 milligrams per kilogram every 2 weeks, plus ipilimumab 1 milligram per kilogram every 6 weeks. Similarly, patients with pleural mesothelioma receive nivolumab 360 milligrams every 3 weeks, plus ipilimumab 1 milligram per kilogram every 6 weeks. Nivolumab and ipilimumab are also FDA approved in combination with platinum doublet chemotherapy for patients with metastatic non-small cell lung cancer. Here, nivolumab is dosed at 360 milligrams every 3 weeks, plus ipilimumab at 1 milligram per kilogram every 6 weeks, along with 2 cycles of platinum doublet chemotherapy. For patients with advanced renal cell carcinoma, nivolumab is dosed at 240 milligrams every 2 weeks or 480 milligrams every 4 weeks, plus cabozantinib 40 milligrams once daily without food. Pembrolizumab is FDA approved for a variety of indications. For patients with melanoma, gastric cancer, esophageal cancer, cervical cancer, urothelial carcinoma, non-muscle invasive bladder cancer, microsatellite unstable or mismatch repair deficient colorectal cancer, hepatocellular carcinoma, cutaneous squamous cell carcinoma, non-small cell lung cancer, small cell lung cancer, head and neck squamous cell carcinoma, and Merkel cell carcinoma. Pembrolizumab is administered at 200 milligrams every 3 weeks or 400 milligrams every 6 weeks. For patients with MSI-high or mismatch repair deficient cancers, tumor mutation burden high cancers, classical Hodgkin's lymphoma, primary mediastinal B-cell lymphoma, or Merkel cell carcinoma, pembrolizumab may be dosed in adult patients at 200 milligrams every 3 weeks or 400 milligrams every 6 weeks. Pediatric patients receive pembrolizumab 2 milligrams per kilogram every 3 weeks. Pembrolizumab is approved in combination with other medications for several indications. In these cases, pembrolizumab is dosed at 200 milligrams every 3 weeks or 400 milligrams every 6 weeks. For patients with endometrial carcinoma, lenvatinib, 20 milligrams every day, is added. For patients with head and neck squamous cell carcinoma, pembrolizumab is added to platinum chemotherapy and fluorouracil. For patients with metastatic non-squamous non-small cell lung cancer with no EGFR or ALK genomic tumor aberrations, pembrolizumab is added to platinum chemotherapy and pemetrexed. For patients with metastatic squamous non-small cell lung cancer, pembrolizumab is added to carboplatin plus paclitaxel or paclitaxel protein bound. For patients with renal cell carcinoma, pembrolizumab is added to axitinib 5 milligrams BID. For patients with triple-negative breast cancer, pembrolizumab is added to paclitaxel or paclitaxel protein-bound or gemcitabine. Atezolizumab is FDA approved for multiple indications. For urothelial carcinoma and non-small cell lung cancer, atezolizumab is dosed at 840 milligrams every 2 weeks, 1,200 milligrams every 3 weeks, or 1,680 milligrams every 4 weeks. For patients with metastatic triple-negative breast cancer, for each 28-day cycle, atezolizumab is administered at 840 milligrams on days 1 and 15. In addition, patients received paclitaxel, protein-bound, on days 1, 8, and 15. For patients with melanoma, atezolizumab is FDA approved in combination with cobimetinib and vemurafenib. This regimen involves administering cobimetinib and vemurafenib for a 28-day cycle, followed by the addition of atezolizumab administered at 840 milligrams every 2 weeks. Atezolizumab is approved to be given in combination with other therapies for several indications. Here, atezolizumab is dosed at 1,200 milligrams every 3 weeks. For hepatocellular carcinoma, bevacizumab at 15 milligrams per kilogram is added on the same day every 3 weeks. For patients with non-small cell lung cancer, paclitaxel plus carboplatin plus or minus bevacizumab at 15 milligrams per kilogram is added every 3 weeks. For patients with small cell lung cancer, atezolizumab is added to carboplatin plus etoposide. For patients with hepatocellular carcinoma, if bevacizumab has been discontinued, atezolizumab is administered at 840 milligrams every 2 weeks, 1,200 milligrams every 3 weeks, or 1,680 milligrams every 4 weeks. For patients with non-small cell lung cancer, atezolizumab is administered after 4 to 6 cycles of chemotherapy, and if bevacizumab has been discontinued. For patients with small cell lung cancer, atezolizumab is administered after 4 cycles of chemotherapy. Dervalumab is FDA approved for several indications. For patients with urothelial carcinoma, non-small cell lung cancer, Dervalumab is administered at 10 milligrams per kilogram every 2 weeks or 1,500 milligrams every 4 weeks in patients that weigh at least 30 kilograms. For patients who weigh less than 30 kilograms, Dervalumab is dosed at 10 milligrams per kilogram every 2 weeks. For patients with extensive stage small cell lung cancer who weigh at least 30 kilograms, Dervalumab is dosed at 1,500 milligrams every 3 weeks, plus etoposide and carboplatin or cisplatin. Once chemotherapy has been completed, Dervalumab is then dosed as a maintenance monotherapy at 1,500 milligrams every 4 weeks. For patients who weigh less than 30 kilograms, Dervalumab is administered at 20 milligrams per kilogram every 3 weeks in combination with etoposide plus carboplatin or cisplatin. When chemotherapy is complete, Dervalumab is then administered as a maintenance monotherapy at 10 milligrams per kilogram every 2 weeks. Evaluab is FDA approved for several indications. For patients with Merkel cell carcinoma and urothelial carcinoma, Evaluab is dosed at 800 milligrams every 2 weeks. For patients with renal cell carcinoma, Evaluab at 800 milligrams every 2 weeks is combined with axitinib 5 milligrams twice daily. Cemiplimab, an anti-PD-1 agent, is FDA approved for patients with advanced cutaneous squamous cell carcinoma, advanced basal cell carcinoma, and non-small cell lung cancer with high PD-L1 expression. Cemiplimab is dosed at 350 milligrams every 3 weeks. The widespread adoption of immune checkpoint inhibitor therapy across a variety of tumor types and the associated improvement in patient outcomes have raised important questions about the optimal frequency of administration of these drugs. While efficacy and safety are the most important considerations, we also take into account convenience, quality of life, and potential to reduce healthcare-related costs. Research efforts examining the risks and benefits of delaying or interrupting treatment or using alternative extended interval dosing strategies have further intensified as a result of the COVID-19 pandemic. FDA approvals over the past few years reflecting an extended interval dosing approach include Nivolumab, administered every 4 weeks, and Pembrolizumab, administered every 6 weeks. Extended interval dosing may mean fewer infusions over a given period of time, potentially increasing convenience and flexibility and decreasing cost for patients. An additional consideration during the COVID-19 pandemic is patient safety and the potential advantage of a reduced risk of viral transmission secondary to unintended nosocomial exposures. The ability to extend the interval between doses of therapy has allowed clinicians to conserve resources and limit patient contact within the medical system. Extended interval dosing may have limitations as well. For example, questions remain about whether dosing schedules based on pharmacokinetic modeling will result in outcomes similar to those seen in clinical trials or real-world studies. As safety concerns associated with the COVID-19 pandemic diminish and it becomes safer to conduct clinical visits and more regularly expose patients to the healthcare environment, it will be important to assess whether the strategies employed over the last year should be adopted for longer-term use in clinical practice. Although randomized non-inferiority clinical trials would be the gold standard for evaluating extended dosing regimens, smaller translational investigations and long-term follow-up assessments from current clinical studies can help clarify some questions and inform clinical decisions. Questions have also been raised about whether population pharmacokinetic modeling data derived from patients with a particular tumor type are generalizable to patients with other malignancies. It is not yet fully understood whether patients with different tumor histologies or treatment characteristics experience similar benefit-to-risk ratios from extended interval dosing strategies. Pertinent issues include the impacts of full or constant receptor occupancy and serum drug concentrations on efficacy and durability of clinical outcomes. Additionally, concerns have been raised about ensuring that patients are monitored and assessed appropriately with respect to disease progression and immune-related adverse events in the setting of extended interval dosing. Many clinicians have needed to adjust safety monitoring protocols for patients who are receiving immune checkpoint blocking therapies at extended dosing intervals to avoid delayed recognition of immune-mediated adverse events. Emerging patient-reported outcome data will also likely factor into future adoption of safety monitoring protocols. As experience with extended dosing regimens increases and safety and efficacy data emerge, there are some important considerations to keep in mind. First, many clinicians find that order sets within electronic provider order entry systems improve accuracy, decrease adverse events, and ensure that patients receive consistent evidence-based care. Order sets enable standardization while allowing content to be modified based on the needs of a specific patient. Immunotherapy dosing order sets can be established in the electronic health record to ensure correct dosing selection for different therapies and indications. This is becoming increasingly important as the number and complexity of available immunomodulatory therapies increase and the indications for use expand. Monitoring for and detecting immune-mediated adverse events associated with immune checkpoint blocking drugs is an important concern with any dosing regimen, but particularly so with extended dosing intervals. In those patients, in order to avoid delays in recognizing toxicities, an effective strategy can be to schedule patients for interim evaluations by telehealth at the midpoint of each cycle, along with laboratory analyses performed locally. Oncology nurses in particular can play an important role in tracking patients through the course of each cycle. Another area of interest is the safety and utility of immunotherapy dose level modulation. To explore this issue, let's discuss two patients with metastatic melanoma. The first case involves a 63-year-old woman whose past medical history includes only hypertension and hyperlipidemia. She presented with metastatic melanoma and, despite being neurologically asymptomatic, was found to have 3 brain metastases, each one measuring 1 to 2 centimeters in diameter. This patient might be appropriate for treatment with nivolumab 1 milligram per kilogram of body weight plus ipilimumab 3 milligrams per kilogram every 3 weeks for up to 4 doses, followed by nivolumab monotherapy based on the Checkmate 204 data demonstrating intracranial anti-tumor activity of that regimen. Of note, this is the full dose ipilimumab regimen using 3 milligrams per kilogram of body weight. The second case involves a 75-year-old man with an ECOG performance status of 2 who presents with metastatic BRAF wild-type melanoma, including too numerous to count liver and lung metastases. Based on the high tumor burden and based on this patient's limited capacity to tolerate a grade 3 or 4 immune-mediated adverse reaction, it would be reasonable to consider administration of nivolumab plus low-dose ipilimumab at 1 milligram per kilogram, the dosing regimen explored in the Checkmate 511 study. This regimen is associated with a lower likelihood of grade 3-4 toxicity than is Nivo1 Ipi3. Although the Checkmate 511 study design only allowed for descriptive comparisons of efficacy among subjects who received the 2 different dosing regimens of Nivo and Ipi, overall response rates were similar between the 2 groups, including across patient subgroups. That ends our discussion for today. We hope you found the activity informative and useful to your practice and encourage you to download the infographic materials for your reference. This is Dr. Evan Lipson from Johns Hopkins University. Thank you very much for participating.
This activity is accredited by Purdue University College of Pharmacy. This accredited activity has been developed in collaboration with our educational partner, PVI, Peer Review Institute for Medical Education.